Welcome everyone to Mamadospr Medical Media, a free online YouTube channel, weekly posting new medical videos. Join our Facebook and Telegram groups for more interaction and latest news. You could also support the channel on Patreon, where we upload multiple choice questions and other premium content. Thanks in advance.
Interstitial lung disease is one of the major restrictive diseases that causes stiffness of the lungs. In this video, I'll cover this as well as the industrial dust diseases. We'll briefly go over interstitial lung disease as well as the three most common types: Idiopathic Pulmonary Fibrosis, Hypersensitivity Pneumonitis, and Sarcoidosis. Interstitial lung disease is more of an umbrella term we use to describe diseases that affect the lungs parenchyma in a diffused manner. It's characterized by chronic inflammation and progressive lung fibrosis, but that doesn't apply to all the diseases that fall under this. We classify it into three groups: those that are idiopathic, as in they have no cause, those that do have a cause, and those associated with systemic disease. The types that have a known cause include idiopathic pulmonary fibrosis, which is the most common type overall, and sometimes goes by the name cryptogenic fibrosing alveolitis, cryptogenic organizing pneumonia, which we used to call bronchiolitis obliterans with organizing pneumonia, and non-specific interstitial pneumonitis. The ones with a known cause include occupational or environmental diseases like asbestosis and silicosis or cotton workers' lung, drugs like amiodarone and nitrofurantoin, infections like TB, viruses and fungi. It could be a hypersensitivity reaction like hypersensitivity pneumonitis, which we call extrinsic allergic alveolitis, and gastroesophageal reflux disease. And you have those associated with systemic disorder like sarcoidosis, connective tissue disease, ulcerative colitis, and acute tubular necrosis. Idiopathic pulmonary fibrosis, which sometimes goes by the name cryptogenic fibrosing alveolitis, is the number one cause of interstitial lung disease. It has no known cause, but causes progressive irreversible pulmonary fibrosis. And these patients have an increased risk of developing lung cancer and can also go into respiratory failure. The risk factors include increasing age, the male sex, smoking, which also includes secondhand smoking, and chronic viral infections like hepatitis C and Epstein-Barr virus. They can present with constitutional symptoms like weight loss, fatigue, arthralgia, as well as dry cough and exertional dyspnea. Signs include the 3 C's: clubbing, cyanosis, and crepitation. For investigations, we'll do blood tests like CBC, CRP, and autoantibodies. Pulmonary function test will show a restrictive picture on spirometry, meaning a low FEV1 FVC ratio and a low diffusion lung capacity. Imaging is the mainstay test with both chest X-ray and high-resolution CT. On chest X-ray, you'll see a diffused patchy shadow and a honeycomb appearance on CT. We can do bronchoalveolar lavage and biopsy, which is diagnostic, but only done when you're still uncertain after imaging. This patient has severe fibrosis, as you can see the fibrotic shadow all over the chest. The disease causes irreversible damage, meaning there's no cure. So the aim is to stop disease progression. We begin with supportive treatment like stop smoking, exercise, weight control, physiotherapy to improve the symptoms, oxygen in case of hypoxemia, and make sure they're vaccinated against pneumococci and influenza. And in end-stage disease, give them opiates as it helps them with the excessive cough. Then we move to medical treatment to slow down the progression. We use antifibrotic agents, and in cases of acute exacerbation, corticosteroids. A lung transplant is last resort, but not everyone is a candidate for surgery. Now, hypersensitivity pneumonitis, it sometimes goes by the name extrinsic allergic alveolitis, and it's technically an allergic reaction due to repetitive exposure to an allergen. So you have someone who has no allergies whatsoever suddenly develops one due to being constantly exposed to an allergen like a fungal spore or an avian protein. The exposure could be for weeks to years before they develop this. The causes include farmer's lung, who can probably get it from moldy hay, bird fancier's lung from a protein in bird droppings. I would say these two are the most common, but then you have other causes like malt worker's lung, cheese worker's lung, and so and so. If these patients present acutely and are diagnosed early, the damage can be reversed, but if the disease is chronic, the lungs have become fibrosed and irreversibly damaged, meaning early diagnosis is important. Acute cases present 4 to 6 hours after exposure, and they present with fever, shortness of breath, myalgia, dry cough and basal crackles. In chronic cases, you have clubbing, increased shortness of breath and weight loss, with cor pulmonale and respiratory failure happening later. Pulmonary function test will show a restrictive disease. On imaging, chest X-ray will show consolidation and fibrosis in chronic cases. CT will give a ground glass appearance or honeycomb appearance. On this X-ray, you can see the areas of consolidation. This is a high-resolution CT of someone with chronic hypersensitivity pneumonitis. It gives you a honeycomb-like appearance or a ground glass appearance like this. Management of acute cases include removing the allergen, oxygen if they're hypoxemic, and systemic steroid like prednisolone. In chronic cases, seen as the disease is irreversible and has no cure, we'll need to do preventable measures and hopefully reduce the progression. We'll advise them to wear a face mask and avoid the allergens at all costs and put them on long-term steroids. Now, sarcoidosis, which is associated with a systemic disorder, is a multi-system disease with an unknown cause characterized by the formation of non-caseating granuloma. It mostly affects those between the ages of 20 to 40 and would affect multiple systems, most commonly the lungs. Then you have the skin, eyes, liver, heart and the nervous system. They present with constitutional symptoms, mostly seen in blacks and Indians, consisting of fever, fatigue and cachexia. They'll present with pulmonary symptoms like dry cough, progressive shortness of breath, decreased exercise intolerance and chest pain. They can get skin manifestations like erythema nodosum in the legs and lupus pernio, which is rare but pathognomic. And also in the eyes, you have uveitis. Now, Lofgren syndrome is more of a subtype of sarcoidosis, and these patients must have arthritis or arthralgia, erythema nodosum, and on chest X-ray, bilateral high lymphadenopathy. For investigations, we'll do bloods like CBC, ESR, CRP, ACE and calcium. The ACE will help us follow the patient's response to treatment. We'll do ECG to help us spot hypocalcemia. Pulmonary function test will show a restrictive pattern. Chest X-ray is the best initial test as it will show us the bilateral high lymphadenopathy. And finally, biopsy is diagnostic and will show the non-caseating granuloma. This is how the chest X-ray looks. As you can see, the enlarged hilar lymph nodes on both sides. So let's say the patient presents with only bilateral lymphadenopathy on chest X-ray and nothing else. They'll recover spontaneously without treatment. Management will give an oral systemic steroid like prednisolone as first-line treatment. Methotrexate is used as an alternative. And if those two are contraindicated, anti-tumor necrosis factor monoclonal antibodies. Now, we have industrial dust diseases, which are the occupational causes of interstitial lung disease. Seeing as these diseases are due to occupational exposure, they're liable to some kind of compensation once diagnosed. I'll cover the essentials as well as the 3 most common types of industrial dust diseases: asbestosis, coal workers pneumoconiosis, and silicosis. I'll talk a bit about mesothelioma, which isn't really an industrial dust disease, but it's closely affiliated with asbestosis. Industrial dust diseases sometimes goes by another name, pneumoconiosis. It's a group of diseases caused by the inhalation and retention of dust particles, resulting in fibrotic changes and granuloma. The time between exposure and the onset of symptoms is quite long, can take years, and we have 3 common types, with the most common 2 being asbestosis and coal workers pneumoconiosis, and the third being silicosis. There are other types, but they're much more rare. Asbestosis is due to heavy exposure of asbestos fibers, which, although rare nowadays, was used in buildings for fireproofing and electrical wire insulation. The exposure has to be over a long period of time, like 5 to 10 years, and they'll present with progressive shortness of breath, dry cough and crackles. On investigations, pulmonary function test will show a restrictive picture. On chest X-ray, we'll see pleural thickening and plaques, and on high-resolution CT, a honeycomb appearance. The plaque will look something like this on X-ray. There's no treatment except symptomatic treatment and vaccination, and these patients are liable to some form of compensation. Now, when it comes to complications, these patients have a high risk of developing lung cancer, mainly non-small cell carcinoma, and that risk increases even more if they smoke. Mesothelioma is also commonly associated with asbestosis. In coal miners' pneumoconiosis, it's due to inhalation of coal dust particles, including silica, over a prolonged period of time, usually 15 to 20 years. It's divided into simple pneumoconiosis, who are usually asymptomatic but have a high risk of developing COPD, and progressive massive fibrosis, who present with progressive dyspnea, cough with black sputum, and eventually develop cor pulmonale and respiratory failure. On investigation, pulmonary function tests can show both a restrictive and obstructive pattern. You'll see fibrotic masses on chest X-ray, and treatment is usually symptomatic while also treating the underlying condition such as COPD and avoiding coal particles. Now, silicosis is due to inhalation of silica particles, seen especially in those who work in factories that manufacture ceramics and pots, and those who mine gold and other metals. The main symptoms is a progressive dyspnea, and on chest X-ray you'll see calcification. The management is the same as coal workers' pneumoconiosis. Now, mesothelioma, it's not really an industrial dust disease, but it's strongly associated with asbestosis. It's a tumour of the mesothelial cells found in the pleura, pericardium and testes, with the pleura being the most affected. These patients have to have been exposed to asbestos fibres, but only around 20% of these have previously had asbestosis. So being exposed to asbestos is essential, but not to the point of developing asbestosis. For this to develop, it takes a long time, around 45 years, and they commonly present with shortness of breath, chest pain and weight loss, as well as signs of metastasis like lymphadenopathy, hepatomegaly, bone pain, and abdominal symptoms indicating peritoneal metastasis, which we call peritoneal malignant mesothelioma. These patients are usually diagnosed post-mortem. On chest X-ray, you'll see pleural thickening or effusion, just like in asbestosis, and the pleural aspiration is blood stain. Pleural biopsy is diagnostic and is usually taken post-mortem. Seeing as there's no cure, these patients can get symptomatic treatment, whereas surgery is only reserved for those with stage 1 mesothelioma.